Thank you. Good afternoon, everyone. Thank you for attending the session at lunchtime. It's great to see you all. I'll be discussing about the D6 steps, how I do it, and I like to be as I'll just walk through a simple routine case that we all have in our OTs. It's a simple corneal decompensation, and since we are moving more and more towards thinner grafts, ultra-thin D6 and PDEC, DMEC, DSEK still holds its place, especially in complicated cases where we don't have very good intraop visualization. And when there is no adequate iris support, vitrectomized eye, those things, I still feel DSEK is a procedure that we should all be doing regularly to have a feel of it. And we start with the manual dissection. I generally cut my tissues with the microkeratome ML7, but manual dissection is always handy. I use a 350 microns guarded knife after mounting the tissue on the anterior chamber. Tissue anterior, I give a firm but gentle groove. One single groove is enough to give a precise 350 microns. If I want a thinner graft, I generally try to do a once more pass with the same knife, but slightly with a less pressure, so that I don't have a perforation, but I have a slight more depth. I generally leave a very small bubble in the AC that will guide me about the thickness of the residual lenticule that I'll be having. I go with the blunt dissection in the center and then reach all the way to the periphery to dissect till the limbus, so that even if in case of a decentered punch refine, I don't end up having a attached anterior and posterior lamella. Intraop visualization is always a challenge in these kind of cases, because most of it, if it's a true scarring or if it's just an epithelial hypertrophy, can be judged by an OCT. Most of the time, 90% of the time, it's a hypertrophic epithelium, since these are long-standing cases and they peel off very easily. And this is a time when we can judge whether we can proceed with the DSEK or we have to convert to a full thickness penetrating keratoplasty, as doing a DSEK in a central corneal opacity is not a very good idea. Though a very superficial scar we can still do away with DSEK and take care of the corneal opacity subsequently. So now I'll go to a routine case, from starting to the end, how I start with it. So I remove epithelium in all my cases. This is a case of early corneal decompensation, and the intraop clarity has improved very well after the epithelial removal. I stain my endothelium with Trypan blue. I wait for about a minute, and then I wash it. So all the areas of endothelial loss are very well demarcated. So for DM scoring, I use a blood Sinski hook. It's important to go all around 360 and get the DM scroll in one go. It's not a good idea to leave bits and pieces there. It can hamper the graft attachment, as well as hamper in the final visual acuity. But sometimes there are cases in where specifically in case of viral endothelitis, silicone oil touch, and young patients where the DM might be quite sticky. There, in these cases, like this was a case of repeated viral endothelitis, we can use a forceps and do a rexus kind of maneuver and take the whole thing in piecemeal. Any remnant tags can also be removed with the help of forceps. Incision, I routinely do a limbal incision 4.5 to 5 millimeters, and with the initial inner lip just inside my graft area, so that the inner lip of my wound is opposed by the graft, and that gives me a very good watertight tunnel. Only in cases where it's combined with a cataract surgery, I do a scleral incision. The advantage is that you get a minimal astigmatism, but the disadvantage of this is that you are going to have a very long tunnel, which is going to shallow your AC repeatedly, and this repeated shallow may lead to endothelial soil loss. So it's a chance that you have to take, whether how comfortable you are with scleral incisions, and ultimately you should have a watertight tunnel, and the wound should not be leaky, and you should not have a post-op hypotony for a successful graft attachment. I use cohesive viscoelastic for Descemet stripping, so it's easier to remove, but it has to be thoroughly removed from the back of the stroma so that it doesn't imbibe any fluid and cause detachment. I use the sheets glide and a push-in technique routinely. Sorry. I use a push-in technique routinely as I feel that it's helped me maintain the graft orientation. So for that, I insert the graft sleeve, the lens slide into the AC, put a mount of cohesive viscoelastic so that my tissue is not touching any of the eye structures or the speculum or anything. I take up whole of the cornea, anterior and posterior together as a complex on the tissue and separate, cause any glare, any visual symptoms, and it makes one step very easy. So thank you very much for your kind attention.